I'm Dr. Shadi Vahdat, Chief Medical Officer of Create Cures Foundation, here today with Professor Valter Longo. Before we start our conversation about diabetes, its associated blood tests, the optimal diet or fast for it, and its relevance to other conditions such as cancer, heart disease, and more, I want to thank you all for your feedback since our first interview on colon cancer. Yes, we're going to try to do shorter videos and to have them on a monthly basis on various topics such as cardiovascular disease, obesity, breast cancer, autoimmunity, and much more. If there are other topics of interest, please be sure and share that with us in the comment box below this video. The other request, Walter, that many people wanted is translation to Italian. Is that going to be an option?
If the foundation makes it an option, it's an option. I think it's certainly something that they can work on. Yeah.
Okay, so on to diabetes. Diabetes is not only a serious problem in China, India, and US, which are the three top countries with the most people affected, but it's estimated to explode in numbers in many developing countries in the next 10 to 20 years. The dangers of this diagnosis rise fairly quickly within 3 to 5 years after diagnosis and include risk of heart attacks, strokes, kidney failure, nerve damage, eye disease, and actually an increased risk for various cancers. I'd first like to discuss how everyone listening today can become more engaged and informed about interpreting their own blood sugar level and labs. And the reason I want to do this is because I'm frankly amazed at the number of patients I see every day who have prediabetes, who meet criteria for prediabetes, the stage before diabetes, and they're completely unaware of it because nobody, not their general practitioner, has brought their attention to it. So in fact, if you live in the US, 1 out of 3 people are thought to have prediabetes and 90% are unaware. So I think this is an important exercise to go through. So I actually pulled up some labs. These are Quest labs, and I wanted to go through what the lab normal values are and actually ask you if you think what is reported on the labs is actually the optimal ranges we should be aiming for. So I'm looking at a Quest sheet, and we first look at on the complete metabolic panel, we look at fasting blood sugar. And fasting is defined as at least 8 hours, 8 to 10 hours of fasting. So if you look at the lab, you will see that normal is suggested for any value 99 or less. If it's a value of 100 to 125, you're considered to have prediabetes, and any value over 126 is diabetes. And for hemoglobin A1C, which is another lab test that we look at for diagnosis, anything over 6.5 is considered diabetes. That's the average blood sugar for, over 2 to 3 months. Now, can you tell us, if someone looked at these labs, an optimal blood sugar would be 99 and less. So if you were 97, nobody would alert you that this is a problem. What do you think about those ranges?
Yeah, I think that 99 is already a problem, meaning that something is not working properly and you're probably insulin resistant, particularly if the HbA1c is also a borderline or over. And so I would say that people should shoot for, let's say, 90 and below. And if you're 90 and below or around 90, then with the HbA1c also, let's say, below 5.7 and probably more closer to 5, right? So the people should shoot for try to get to around 5 for A1c, and then, let's say around 90 or below. I think ideally, say between 75, 78, and 90. If you can stay in that range, that means that everything is in the right place. Now, the people can come to you and our clinics, and we also recommend now the continuous glucose monitor. I think it's a very good idea. With a doctor, followed by a doctor, that people look at 2 weeks. And we've done it for a number of patients, and it's so informative because you see the what happens to the glucose level after each type of meal. So some people will eat something and nothing happens, and another person will eat the same identical thing, say potatoes, and they'll get the glucose spike in 250. So I think it's that's something that we recommend. and that people can do to just get an idea of how each food that they eat affects their glucose level. And the spike is not just a temporary issue; it's also something that can contribute to the average, glucose level and to the fasting glucose eventually, if it leads to insulin resistance.
Yeah, I totally agree. And we try to actually, for people who are okay with that, we order it and see if their insurance will cover that. So I think it's very informative, not only with what they eat, but also exercise and activity. So there's some studies suggesting, after a meal, if you, move and have some exercise, it actually helps to bring that blood sugar down. So I do think it's very informative. But I just kind of wanted to make a side point that, when I looked at the formal recommendations for these values, an endocrinologist may be happy with when they're treating people with metformin or various medications, may be happy with a hemoglobin A1C of less than 7, because the microvascular changes, the kidney disease, the heart disease risk will be lower. So how we use these in different patient populations and different diseases may be very different. If you're an elderly, frail person who has a lot of low blood sugar, drops and might be dizzy and have a fall risk, you might need to change these numbers. So when you say a hemoglobin A1C of 5.5 or 5, we have to be cautious because it needs to be personalized to who you're treating. But especially I want to ask you, in our, cancer patients who don't have a formal diagnosis of diabetes, are there certain conditions you would like to see lower fasting blood sugars?
Yeah, in general. So this is why I was talking about, let's say 78 to 90. That's very safe, right? So if you're starting to look at, like what happens after calorie restriction, you can get to 60, 55, right? That's when that's a problem zone. But if you let's say stay above 80, for most people, including the elderly, that would be an appropriate number. So I think that the range that I was describing is a range that seems to be good at all ages. So in our clinical trials, we go all the way to, 80, 85 now with the Alzheimer trial, years of age. And so those are probably good numbers for everybody. For cancer, it's a different story, because for cancer, it really depends. It is even more personalized, right? So what are you trying to fight? So are you a stage 1 patient who's going to receive a surgery and then probably done with it? In that case, you probably want to lower your blood sugar still to the, let's say, 70 to 80 and keep it there. But in some more aggressive situations, it may be that you have to be much more aggressive, and then you're going to need the oncologist, you're going to need probably an internal medicine physician and a dietitian working as a team, and that's what you do at the Create Cures clinic, Dr. Vahdat. So I think that's probably necessary to say push the glycemia to a more uncomfortable range, let's say 60 to 70, and keep it there, because for some tumors we're seeing that they're very much, some colorectal cancer, some say triple negative breast cancer, they're very much sensitive to the glycemia, and there's now a number of correlative studies where they see that the women that have higher glucose levels, fasting glucose level, they have a worse prognosis.
So I'm going to move on to another blood marker, which is frequently not checked. It's not in a routine annual. And even if you ask your primary care provider, they may not want to order it, but it can be give you a lot of information. And what I'm talking about is checking the fasting insulin. Oftentimes, rising insulin levels will precede the high blood sugar and the high hemoglobin A1C by years. Or sometimes even decades. So this is something that we routinely check in the clinic with our patients, because we want to catch this, as soon as possible. And so I will let you actually talk about what is the problem with a high insulin level. And just I think you'll be amused that if you look at a Quest lab, it says normal levels of insulin is anything less than 19 is okay. So can you tell us?
Yeah. Well, I mean, right, high insulin is a big problem because it's basically saying that your glucose is maintained not by your insulin sensitivity. So your system is not working very well, but it makes a ton of insulin to take care of a problem, right? And eventually that's going to burn out the beta cells in the pancreas, and eventually not only you're going to be diabetic, but you're going to be dependent on insulin. So I think that the what needs to happen is that the insulin needs to come down as much as the glycemia needs to come down, and that probably comes from major dietary changes that again are implemented by the team, at least initially. That most people can do them on their own once they make the right changes.
Yeah. So again, for people who don't know the physiology, when you do eat, when we eat, and if there's carbohydrates, the pancreas releases insulin to be able to put that glucose into the cells of our body. And so when, in type 1 diabetes, of course, patients are unable to, there's damage to the pancreas, so they can't secrete the insulin. In type 2 diabetes, essentially what's happening is this insulin resistance. And aside from high blood sugar and diabetes, what other, I mean, this is important for a lot of chronic conditions, right? Can you mention, I mean, whether you're talking about fatty liver, metabolic disease, cardiovascular disease, it's not just a diabetes problem.
Yeah, you mean the high glycemia, the high sugar level? Yeah, I mean, the sugar seems to be one of the molecules that accelerates the aging process more than anything else, in addition to proteins, right? So, in certain amino acids. Certain amino acids and sugar seem to be driving the most organisms, not just human beings, most organisms to age more quickly. So when you have a high sugar level and high amino acid level, so high protein level, that's telling the system, go, reproduce, grow. Don't worry so much about aging, right? Don't worry much about damage. Focus more on reproduction. And of course, most people reproduce only 0 times or very few times in life. So the rest of the time, you want to keep the sugar level sufficient, but not so high that it's going to push the system to do more than it should. And so then glucose levels can be at the center of so many things, including cognitive decline, Alzheimer's, cardiovascular disease, cancer, et cetera, et cetera. Probably also lots of infectious diseases, right? The sugar microorganisms love sugar, whether it's yeast or even bacteria. So high sugar or high starch diets is, and certainly high blood sugar level. So anything that turns the sugar level higher in the bloodstream can also contribute to infectious agents and infectious diseases.
Right. So this is a good time to go on to the best diet. I think the biggest point of confusion is what is the best diet for patients with prediabetes or diabetes. And as you know, in the last few years, we hear all sorts of things from well-known experts. Some people are talking about ketogenic diet. Some people are talking about lectin-free diet, high protein, low carb. I'd like to go through these one by one, each of these diets, and get your opinion. So a lot of people, as you know, with elevated blood sugars feel and adopt a ketogenic diet. And as, again, both of us know, that is in the short term can bring blood sugars down and even help with weight loss. But can you tell us, and you've researched this for quite a long time, what is the problem with this type, potentially, if used long term?
Yeah, so the ketogenic diet, whether you look at mice or you look at studies, meta-analysis of all the clinical studies ever done, a ketogenic diet shortens your life, right? The only exception is that if you look at the Harvard study, the physician and nurse study, is the low carbohydrate, so ketogenic, plant-based, right? So that seems to be actually pretty good. And there's not enough studies to know, right? What will happen if somebody adopted a very low carb mostly plant-based diet. Who knows? But at least some data suggests that could be very good for you, even in the long run. But generally, the ketogenic diet, the typical animal-based, lots of animal products, very low carbohydrate, that shortens the life of mice and humans. So not a good idea. Now, short term, is it a good idea? I don't think so, even short term. Why? Because you're not going to be able to maintain it. It's a short fix. And so I would say, unless you're working with a physician and somebody that says, okay, let's use it for 8 weeks and then let's switch you, because that's the only way we can get you to lose weight, then I think it's okay. Other than that, I think it's probably just not such a good idea. Temporary fix. Most people will go back and not be able to handle. I mean, people love carbohydrates. The great majority of people do. And so it'll be difficult for most people, the great majority of people, to do this long term. And if you can't do it long term, you're probably better off finding something that you can do long term.
And is it not true that some of the studies show that if there is weight loss, some of that is coming from water and muscle loss in these diets?
Most studies are showing lean body mass loss together with the fat and the water loss, right? So almost, I mean, with the exception of a few that I've seen, the great majority of them will have loss of all three.
Okay. Moving on to the high protein, low carb diet. And there's some data that these high protein diets actually increase your risk for diabetes. My question to you is, are these only with high protein coming from animal protein sources, or is there a differentiation in the studies in terms of, is it all protein, or is it obviously worse with animal protein? But can you tell us about these high protein diets?
Yeah, high protein in general is a bad idea, and I'm just going to say don't do it. I can have we've been working on the bad role of protein for 30 years, since the Walford years. So I could tell you just so many studies showing that's a bad idea. And don't forget that diabetes is not the only problem people have in life, right? So then you have to worry about cardiovascular disease, you have to worry about cancer, you have to worry about dementia. So I think just don't do high protein no matter what. Bad idea. Proteins are driving growth hormone, IGF-1, all these growth genes that I told you accelerate the aging process. Proteins are also seem to be driving the connection between obesity and insulin resistance, right? So in the larons, in these individuals, and also in the mice that have low growth hormone IGF-1, we never see, even though they become obese, we never see diabetes, right? So that's suggesting that the high protein level are also driving, are key or important for insulin resistance, or at least the consequence of having a high protein diet. So yeah, so with that in mind, I would say just stay away from, don't turn high protein into no protein. This is the mistake a lot of people make. Like, oh, you told me not to do high protein, now I'm just going to not eat protein because protein is not bad for me. No, proteins are not bad for you. Proteins are essential, but you have to have about 0.37 grams per pound of body weight. So if you weigh 100 pounds, you're looking at about 40 grams of protein. If you weigh 150 pounds, maybe 50, 55 grams.
Do you think that those protein amounts, I mean, if you're on a plant-based diet, can you go higher? Is there different, meaning is it all protein still is a problem regardless of the source, correct?
No, yeah, it's very important where you get it from, right? So some like legumes have very low levels of certain amino acids, right? So we know that lots of vegans become malnourished because they don't have the right combination of protein sources. So it should be legumes, seeds, and nuts, right? You have legumes, seeds, and nuts, and then you have the right level, then you're okay. But if you just have legumes and you have, let's say, the 40 grams that I just mentioned, then you could become malnourished.
That takes me to my next question. When patients see that they can consume legumes and pasta, that people tell me this all the time as new patients, when they see that they can have those on a longevity diet, they're shocked at how that kind of a diet can be effective in blood sugar control. Can you tell us why it works? Is it the portions? Is it the balance of nutrients and minerals and fiber? Why does it work? Which we see work all the time in the clinic.
Well, it works because people confuse carbohydrate and starches with excess carbohydrate and starches, right? So it's just this black and white. We get into this black and white, yes or no, and it doesn't work like that. Unfortunately, this is why the physician is so important and the dietitian is so important, right? So it's not that complicated. You don't need a big manual to figure it out, but you need to have enough information, enough explanation to say, okay, I got it. So, for example, in a great dish with pasta, you have about 70 grams of pasta, and you have about 300 grams of legumes, and you have another 200 grams of mixed vegetable, right? So that's the ideal dish, right? And each population has a different version of it. Like the Okinawans might have had, the rice and the sweet potatoes and the purple potatoes. So and the Costa Ricans have their own version, and the Greeks have their own version. So I think that is a good. There is a good meal that is going to make you lose a lot of weight, by the way, right? So not gain weight, lose a lot of weight. And now, different people lose weight differently. So some people, let's say that you have that, and then you have bread, and then you could get to a certain point where normal becomes excessive, right? So as that becomes excessive and you starting to gain weight, then you have to reduce the starches, the bread, the potatoes, the rice, the pasta. Say you've probably gone over the limit. So come back and reduce it back to what it is that allows you to keep a good weight, a good also fat mass, right? So you want to, probably if you're a woman, try to stay for sure, let's say below 25, 26% fat, right? Mm-hmm. And a lot of women and men don't realize, but they may be relatively thin, but then they might have 32% fat. And so that means that probably too many starches, too much fat in the diet, and too many or too many of these simple carbohydrates that then are quickly becoming sugars.
Right. Talking about black and white, this is something that you talk about quite a bit in terms of time-restricted eating, and why in your book and many places that you're interviewed, you talk about the 12-hour window as being important. And it's always interesting to me how people get very passionate about, but having a 14-hour fast or 16-hour daily fast is better. And they want to kind of pin you down to a specific, amount of time that everybody needs to do. Can you talk about why you say 12 hours? And also, I see a lot of people, and again, personalizing is so important. So let's say, people are on a longevity diet and they're still maybe they're on steroids or prednisone or other medication that are making them hyperglycemic with a high blood sugar. Can you modify that on a case-by-case basis?
Yes. So, first of all, I think, I always tell people, if you look at nutrition, you're looking at thousands and thousands of ingredients and tens of thousands of genes, and they're like meeting at some point, right? So even though people like to make this a very easy discipline, it's extremely complicated, almost more complicated than I can only think of neurobiology. A lot of my time is spent on researching neurobiology. So neurobiology is the only thing that gets close to the nutrition and health span. So so then leave it to us, and I think the 12 hours is a very good common denominator. What does it mean? It means that no matter what you look at, people that do 12 hours of fasting, so eat, let's say 8 a.m. to 8 p.m., fast 8 p.m. to 8 a.m., they seem to be doing very well. And there is really, I never seen a negative study about that. Not one that I've ever seen. Maybe there is one, but I could never find it. Lots of negative studies when you see 16, 18 hours of fasting every day, and lots of negative studies when you see 8 hours of fasting every day, right? So if people that eat too long, 15, 16 hours a day, they do very poorly. And people that fast, let's say skip breakfast, they eat dinner and then they eat lunch again, they seem to do poorly too, right? The people that do 12 hours, they seem to do very well. So I would say, we're really in the business of getting people to be 110 healthy, and let's say up to 60 young and up to 110 healthy, and so please listen to us if you want to get that, and don't try to improvise. Don't try to say, oh, but I feel good with this 16 hours. That's not the point. The question is, are you going to feel good 12 years from now, 14 years from now, right? So You don't want to be doing something that makes you feel good and may lose weight or whatever for 14 years, and then it gives you, a heart disease or some other problem.
You mentioned something that comes up all the time, and the patients that we see are very well versed in intermittent fasting and are very knowledgeable, but not probably 9 out of 10 times, 8 out of 10 times, people are skipping breakfast. And so what they're doing is, having their first meal at 12 or noon, and they think that's okay. Can you tell us what the studies show?
Yeah, the studies show that you're going to live shorter, right? Not only you're not going to live longer, but you're going to live shorter. So people skip breakfast, study after study after study. And we did our own analysis of the enhanced database. Sure enough, shorter lifespan. So yeah, you can say, well, people that skip breakfast, they have bad habits, and it's not the skipping breakfast that is the problem. But I always say, think about it. Even if it was something else, why is that? If it was beneficial to do skipping, to do fast for 16 hours and skip breakfast, why don't we see them at least to normal, right? Not an extended lifespan, but a normal. Why do we see them living shorter, right? That's very, must make you worry, right? That means there's something there that is not that good or not good enough to counterbalance or to eliminate whatever problem these people may have together with, of course, most of these studies are just for smoking. So it's not like it's a simple explanation like that. But even if it's a more complex explanation, they're doing something else, they're not sleeping very well or whatever. Say, well, why isn't then this 16 hours of fasting helping them overcome the sleep problems, right? And so that's why we say, 16 hours could be good if you're gonna do it for a couple of months, just to give you a boost. Let's say that you wanna lose weight or get in a healthier state quicker. I think it's probably okay to do a couple of months of 16 hours. Let's say even skipping breakfast, but don't get into the habit of it. I think it's much better to skip lunch or have, let's say, a coffee for lunch, and then have breakfast and have dinner, and then have a low-calorie snack in the middle of the day.
Well, there's better ways to do 14 or 16 hours. I think rather than skipping breakfast, you could do an 8 to 6 or 8 to 4 or 5 p.m. and that's still a little bit more in sync with the circadian rhythm. So, I think you start when you're skipping breakfast, then that sort of creates other issues. The big question everybody wants to know is, does having the morning coffee break the fast?
No, the coffee does not break the fast if there's no sugar. But the coffee does have caffeine and other ingredients which could act as drugs of some sort. But it's okay. There's nothing wrong with coffee. But I would say have breakfast, right? So don't skip breakfast and have coffee with breakfast. And
well, people are having coffee and not counting that as the first,
that's skipping breakfast, right? So if you just have coffee and you have nothing else, you're skipping breakfast. So that's a bad thing to do, right? So I have coffee with breakfast, and then also, we don't know what the concept. We know the skipping breakfast is bad or it's associated with bad outcome. We don't know if skipping dinner is also bad, right? So this is why I was saying lunch is the safest one. So stay within the 12 hours, and if you have to skip anything, skip lunch or the snack in the afternoon or in the morning, but have breakfast and have dinner.
I'm going to skip some of my comments on circadian rhythms, so just in the interest of time. So let's say that patients have successfully transitioned to the longevity diet and still have, for other reasons, whether it's steroid use or gut health issues or poor sleep, they still have persistent high blood sugars. Can you tell us what we know from the preclinical and clinical studies with respect to overlaying a good daily diet with FMD? And in sort of part 2 of that, would you recommend it for both type 1 and type 2 diabetics?
Yeah, okay. So the longevity diet, first of all, is a pescatarian diet, low protein, but good, enough protein, a variety of proteins, a variety of foods, fish maybe a couple times a week. or vegan, but again, then you have to have the seeds and the nuts together with the legumes. So yeah, then in addition to that, we recommend the fasting mimicking diet, 2 or 3 times a year for most people that are relatively healthy, and that's a 5-day low calorie, low protein, low sugar, high good fats diet, and yeah, that seems together. I would say there's going to be very few people that if they do the longevity diet and they do the fasting mimicking diet, very few people that we see not responding, whether they have pre-diabetes or they have obesity. We just finished a trial on diabetic patients. I cannot talk about the results, but certainly I can say that I was surprised the compliance was very high. This is 1 cycle a month for 12 months. And so I thought that we would get a lower compliance, but this was not longevity diet and fasting mimicking diet. We just fasting mimicking diet once a month for 12 months. So I think each person has to decide what they can do best. Some people might just do the longevity diet and maybe once in a while the fasting mimicking diet. Some people might say, you know what, I can't deal with any change in diet. I love my diet, and so just give me this box once every month or 2 or 3. I'll do that for 5 days, and then I go back to whatever it is that I like to do. So yeah, and some people might mix it up. Yeah.
Can you tell us what diet those people were on, or different? The diabetes study that
whatever. Diabetes and whatever diet got them there, right? So we told them.
So whatever they were doing.
So keep doing what it is that you can do, and but once a month you get a box. You consume what's in the box for 5 days, and then you go back to your regular lifestyle. And of course, the idea is to make the fasting mimicking diet much more like a medicine, a controlled medicine that replaces all your food and makes it also very simple for people to do, and not doesn't need to come with a manual. Oh, you need to do this and that and that. And so people are not pharmacists, and that's why I think it's so important to have a standardization and eventually FDA approval of this fasting mimicking or food drug-like food. Yeah.
Can you tell us how much it will impact? I mean, monthly is a little bit different than some of the other studies. How much it will drop the blood sugar, hemoglobin A1C, or have we looked at what happens to insulin with regular use?
Yeah, so we published that with the pre-diabetic, and that worked very well. Almost every pre-diabetic moved back to the normal range, and the drop was pretty good for most people. And there is a drop in insulin, there is a drop in glucose, there is also a drop in IGF-1, which is probably contributing to as I was saying earlier, to the insulin resistance. And so I think we're about to publish 2 more studies that have diabetic components in it, but they're not looking at diabetes. And then the big study, hopefully, is going to be published in the next 6 months with actual only diabetes patients, also diabetes patients that are receiving metformin and some other drugs. Type 1 diabetes is much more complicated. We're about to start the trial with children, believe it or not, in Gazzini Children's Hospital in Genova, Italy. And we'll see. I mean, in mice, it worked very well. I mean, we could reverse type 1 diabetes or certainly the inability of the pancreas to make insulin. It's a big challenge, of course. Human type 1 diabetes, autoimmune disorder. So, that would be, it's a tough one, let's say, right? So, because you have to go after the autoimmunity and at the same time regenerate or generate new insulin producing beta cells in the pancreas. So it's a tough challenge. So I always like to be optimistic, but I realize that this is a tough one. I mean, for type 2, I would say I would be shocked if it didn't work. I would be extremely disappointed. But for type 1, it's a tough one.
And in my personal experience, I've certainly had type 1 diabetics on insulin pumps, and they have done FMD and have done well. But it takes a certain person, who's very compliant with checking, and a certain, physician who can kind of walk this. This should not be done on your own if you're a type 1 diabetic.
Absolutely not. Yeah, and consider that you have such an insulin sensitization in those 5 days, right? So somebody might usually get a shot of insulin, X amount, and the nurse might be giving it to them. I'm even worried about the hospital, right? So I thought that by giving the same dose that normally have a certain response in the glucose level, now you can get a 2 or 3 times larger response, and you could get the patient in trouble. So yeah, this is very dangerous. For the combination of insulin injection and fasting making diet is very dangerous. So please don't even do it with an endocrinologist. Do it in a clinical trial only, or somebody that really understands the dangers and is. And I would recommend to the endocrinologist to not do it unless there is a clinical trial set up and they involve us in this process. Yeah.
One quick last question. Despite all that you've told us, and how we can change our daily diet and fasting, and how these are all very powerful for not only blood sugar but a multitude of things, inflammation, weight loss. There are going to be some people that on that cusp or pre-diabetes or early diabetes who think, well, I'm just going to take metformin and that's going to help the numbers. What do you say to those people? Are you fully protected?
No, well, I mean, the problem is you're not gonna make it to 110 healthy, right? So that's what we're worried about. Yeah, I mean, metformin can work. It works for several years. The question is, are you on your way to escalate then to next drug and then next drug? And that's what happens to most people. So you start with metformin, you end with insulin injection, right? So that's what we're trying to avoid. So we're basically saying you got to fix the problem, right? So what is the problem? The problem is that by eating all the time, in the old days, we used to have eat a lot of food in the summer, you become overweight, you become insulin resistant, you become diabetic essentially. So you can put fat, you can store fat, right? Then the winter comes and you have 1, 2, 3 months where you eat almost nothing or very little, right? And that works, right? Because now you create, let's say, pre-diabetes, and then you eliminate pre-diabetes. But if the winter never comes, because in the winter you eat as much as in the summer, now that's going to continue. And now if you continue that and you take metformin, you just put in a Band-Aid. You have 2 problems now. Now you used to have 1 problem, and now you have a second problem. Why? Because now pharmacologically you're interfering with lots of things: the mitochondrial function, gluconeogenesis. Metformin is a powerful drug blocking. That's a lot of good things, right? So I'm not arguing with it, but it's also a drug, right? So what you want is fix the problem. So, hey, I used to work very well now why are things not working well? Fix it, right? So fix it by reducing the fat in the liver, the fat in the abdomen, and then reverse the insulin resistance, go back to everything working properly. And that's the way to get to 110 healthy and not, and also mentally, I think, people underestimate, I think, that the power of doing it, fixing yourself, fix yourself, because mentally that's a big thing for you, for your well-being, because now you have intervened. Even though it's difficult, right? It's difficult to change diet. It's difficult to do, let's say, the fasting mimicking diet. Or it's challenging. That's part of the process. Overcome that challenge, get the help of the doctors, et cetera. But then that's the way to go back to a very healthy state and not the Band-Aid.
Yeah, I think you bring up an important point that I think sort of all this knowledge and all the things we're talking about, I hope that it puts the control back in the patient's hand, because we really can do, and each person can do so much to help themselves. And by knowing what to look for, by asking the doctor, by working with the right kind of team, there's a lot you can do to reverse many of these chronic diseases. With that, we will wrap up today's conversation on diabetes. We hope you enjoyed it and will join us for these monthly series. Our next topic of interview with Professor Longo will be announced shortly in the next couple of weeks. I'd also like to mention that for additional interviews between myself and other doctors, some integrative, some not, you can check out our additional content on our Create Cures Foundation Facebook and Instagram. And we look forward to seeing you soon.
Thank you.